Welcome to the mini lecture on sensitivity and specificity. In this module, we will discuss the validity of tests and measures using sensitivity and specificity. This presentation should continue with no input from the participant. If you want to pause or skip back or ahead, use the controls on the top or the bottom of the presentation. First, let's define validity. This is the degree to which an instrument measures what it's intended to measure. Here's an example. Let's say we want to measure whether or not a woman is pregnant. The instrument we'll use is a pregnancy test. We'll make a couple of columns up here on the right to represent the possible outcomes of this test. So we'll have a column for the test result, which is either going to be a positive result or a negative result. And then we have the target condition, either pregnant or not pregnant. And we're going to see how these two columns match up. So if the test is valid, it will correctly show a positive sign if the woman is actually pregnant, actually has the target condition, and it'll show a negative sign if she is not. So these are our true positives and true negatives. If the test is not valid, then it has a better chance of showing a positive result even though the woman is not pregnant, and vice versa. It will come up with a negative result even if the woman really is pregnant. So these are called our false positives and false negatives. So if you want to think about it this way, let's assume that the pregnancy tests that are more expensive are the most accurate or the most valid, giving positive and negative results to the right women. And let's assume that the cheaper versions are not as accurate. So this may not actually be the case, but for argument's sake, let's say it is. So if this is the case, the more expensive pregnancy tests are more valid or more likely to give the right result, and the less expensive ones have less validity or are less likely to give the right result. Now let's take a physical therapy example. We want to measure tensor fascia lata, TFL, or IT band tightness in our patients, and this is done using the Ober test. In the Ober test, the patient is side-lying on the non-tested leg, and the tested leg is put into a position that we think measures whether the IT band is tight or not. So if the Ober test correctly identifies patients with IT band tightness, it is a valid test. But if the test is giving positive results when the patient doesn't actually have the condition, then it is not a very valid test. Let's look at the validity of the Ober test by comparing the target condition to all the possible results. So let's draw a little chart here. So we've got the target condition, which is either positive or negative, and then on the left-hand side, the results of the Ober test, which also can be either positive or negative. And if we draw ourselves a little chart here, patient actually has tightness of the IT band, and the result does come back positive, then we say that we have a true positive. If the patient does not have the target condition or the tightness, they're negative for that, and the test does come back negative, then we have a true negative. And what about these other squares on the table? If our Ober test is revealing that the patient does not have IT band tightness, but they really do, then we are here, and we call it a false negative. A negative test result that is actually a false result because the patient does indeed have the tightness. And then in the upper right-hand quadrant, if our Ober test is revealing that the patient does have IT band tightness, but they really don't, then we are here. We call it a false positive, a positive test result that is actually a false diagnosis or result. I'm going to label each one of these quadrants with A, B, C, and D, so we can do some quick math in a minute. Now let's get to sensitivity and specificity. The validity of a diagnostic test is evaluated in terms of its ability to accurately assess the presence or absence of the target condition. So basically, sensitivity is the result of the left side of the table, and specificity is a result of the right side. Let's break this down a little further. Sensitivity indicates the ability of a test to identify true positives accurately, And specificity is the ability of a test to identify true negatives accurately. So first we take all of the people that have tested positive with our over test, and then we put that in our equation as A on the top. That's the proportion of patients who test positive. Then we take the entire group in that positive diagnosis category, A plus C, and that, of course, is all patients who actually have the IT band tightness. So, for example, we have testing results that reveal that 5 people have the tightness, and we have 10 people who actually do have the diagnosis. So that's a 50% sensitivity rate or proportion. So if one were to use this test in the clinic, it really only has about a 50% rate of working, which is not so good. So, by the way, the Ober test in real life has never been studied for validity to my knowledge, so these are sort of made up numbers. Specificity indicates the ability of the test to identify true negatives accurately, or the probability of obtaining a correct negative test in patients who do not have the target condition, in this case, IT band tightness. So first we take all of the people that don't have the condition, and the Ober test got the correct negative result, or quadrant D. Then we divide that number by all of the people who actually do not have the condition, or B plus D. So this calculation gives us the percentage of true negatives, or the probability of obtaining a correct negative test in patients who don't have the tightness or the target condition. So, for example, we have 10 people who do not have IT band tightness, and we do the Ober test on all of them. Our testing results reveal that 7 people have a normal length IT band, or TFL. These are the true negatives. They do not have tightness, and the result of the Ober test was no tightness. So that's a 70% sensitivity rate or proportion. If one were to use this test in the clinic, it has about a 70% rate of working, so better than 50% from our previous example. So obviously we want to have higher rather than lower numbers for sensitivity and specificity. The higher the numbers, the more confidence we have in the interpretation of the result of the test, in this case the Ober test. So for sensitivity, this means higher values indicate the test will rarely give a negative result when the person does actually have the condition. Or in other words, false negatives are unlikely. And then for specificity, this means that higher values indicate that the test will rarely give a positive result when the person does not have the condition. So false positives are very unlikely. An easy way to remember this is by thinking of 2 words, snout and spin. So you can see by the underlined words that these words are acronyms for the principles of sensitivity and specificity. So if we take snout, you can see here that it means with high sensitivity, a negative test rules out the diagnosis, or false negatives are unlikely. So what this means is when a negative test result is obtained, and we're on the left side of the chart above here, the clinician can say with confidence that the condition can be ruled out because false negatives, or falling into quadrant C, are unlikely with high sensitivity. Then on the other one, for spin, we say that it means with high specificity, a positive test rules in the diagnosis, simply because false positives, or quadrant B, are unlikely when you have high specificity. So when a positive result is obtained in the test, whether it's Ober or something else, the clinician can say with confidence that the condition can be ruled in because those false positives in quadrant B are going to be unlikely when you have high specificity. For more great study tools and information for physical therapy students, please visit theptstudent.com.